Hey guys, so one of the things that me and Glenn were discussing earlier in regards to shoulders is symptom modification. Jeremy Lewis is one of the physios in the UK who's most renowned and most well known for this. And different people will do it in different ways, and I think what we'll do in another video is maybe go through a bit more specifically in terms of the Jeremy Lewis method of how he uses that sort of stuff. And you know, I think there's courses that he does as well into the shoulder, and I highly recommend that you check those out as well. But we're just going to talk a little bit about what we do clinically and how helpful it can be. So Glenn, let's first of all, how would you use that symptom modification stuff with your patients?
I think, as the name sort of suggests, you want to find something that reduces the symptoms. So why don't we take flexion, shoulder flexion, as an example.
Yeah.
So if our client is getting pain in this range, in flexion, we want to try and do a couple of things around here to see if we can reduce that pain and modify the symptoms.
Mm-hmm.
So one of the first things I go to is scapula. So if we can give the scapula just a little bit of assistance. I'm going to come around the back actually. And it's really important that you don't, move the scapula completely, because I don't think there's any shoulder problem that wouldn't benefit from me taking hold of the shoulder blade and moving it through the range. Mm-hmm. But you're just giving a little bit of assistance. So if we repeat that movement, I'm just pretty much pinching my fingers together on the inferior border of the scap and back down, and we're seeing if that's changed. Yeah. So is it better, worse, the same?
Yeah.
I like to use a bit of muscle activation as well. So same movement. If I get him to just push gently, so a little bit less pressure than that, Patrick. Just very, very gentle pressure out to the side. Hold that pressure, maintain it throughout, and then come up into flexion. I'm just using my fingertips. When you first do this, clients will try and push your arm through the wall, so you have to make sure it's very gentle. Again, better, worse, the same. And then you can go the other way, pushing in, and the same thing again. Maintain that pressure constantly. Don't let them ease off on that at any point, and keep that pressure down. Yeah, and it's all relevant information. So if it feels better, you can have an exercise stem from that. Yeah, and you can hypothesize what you think's going on to create that. If it's better when you press in, for example, you might be thinking you're activating subscapularis more, or something like that, and creating more clearance in the glenohumeral joint. Mm-hmm. But what is great for me is that it really guides those initial treatments. Obviously AP on the humeral head as well. So I like to do that in this position where you're just pressing down on here, and then I'm putting a posterior force through the humeral head. I'm seeing if that changes. This is similar to what you do as well, isn't it? So I really liked your handling when you were looking at the pressures on there. So.
Yeah, so just again, so Patrick, if you come into standing, so if we, very quickly actually, if we get you turning around, so think in terms of what Glenn was saying there, essentially you're just pinching that inferior angle, and then you're just assisting it, guiding it on the way up, and again, I would probably come a little bit more into that position and then back down. And don't be afraid to do it a couple of times. You can mess around with it a little bit. Again, this is symptom modification, and what we know about this is that we don't know exactly all the time what we're affecting, but what we do know is how that affects the symptoms, and therefore, like we said, it's a really good one to guide treatment. So it may be that you're thinking, if that is positive and is less painful when he does that movement, that we need to do some work on stabilisation of the scapula in order to reduce that pain. And again, it guides what exercises you're doing. With regards to that humeral head, so if you come back round, Patrick, all the way back round to, yeah. So I'll tend to really kind of come onto that humeral head and really feel like I'm controlling it, and actually then just almost drawing back slightly, so, and then coming up all the time and back down, and I'm essentially centering, or I'm imagining that I'm centering essentially the humeral head inside the glenoid as I'm doing that movement. And then does that make it feel better as I do that? Okay, and again, sometimes it will, sometimes it won't. Different patients, even patients with the same diagnosis, are going to have different reasons for that, and therefore these are all going to be different. But it's really going to guide your treatment in terms of what you do with them. And I think that patients get much more buy-in because they can see, oh yes, that did make it feel better, so they feel more confident leaving the session that these exercises I'm going to do are actually going to make a difference. I think that's a big thing as well.
Yeah, I think you have a really important thing with these tests, and the really valuable thing for me is I will ask them what's the number one test that was the most dramatic.
Yeah.
So it's multifactorial quite often. There might be a bit of poor scapular mobility, stiff glenohumeral joint as well, so you might get improvements with all of your tests potentially, but you want to have your main objective marker really. What was the main test that gave them the maximum benefit, and then that would be your initial treatment guided from there.
Yeah, perfect. So it's just a brief introduction into symptom modification. As I say, I think that we might go through a bit more of a completely structured video, but just a nice quick video that you can use straight away in clinic in order to have a look with your patients to see if these things do have an impact, and then direct your treatment towards that.